Hello, everyone. This is Michael Hogue. I'm happy to join you this week again to discuss COVID-19. This is an open forum for pharmacists brought to you by the American Pharmacists Association. As I said, I'm Michael Hogue. I'm the president of APhA. We've been doing these webinars weekly now for several weeks, and we know that many of you have joined us all along, and we welcome you back today for today's program. We have a great lineup today with lots of details. We're going to discuss recommendations for pharmacists who are providing immunizations during the pandemic. And we'll also look ahead a little bit to the fall season and influenza season, as well as provide an update on COVID-19 vaccine development. But I do want to just go ahead and level set with you. We're not going to spend a ton of time today on COVID-19 vaccine itself. We just don't have time to get into all of the details about the vaccine development, but we'll talk about process and how pharmacists are going to begin thinking about implementing COVID-19 vaccines into already hectic practices. So we'll be sure to do that. And then I'm really excited today to have a couple of our APhA staff people with us to be able to share with you some details about the billing and payment for COVID-19 testing in the Medicare program. Our National Pharmacy Associations had a great meeting with the Department of Health and Human Services, and we're able to get a little bit more clarity on these items. We'll share that with you today after we've had some time first to talk about the vaccines. Now, let's get started. I want to cover, first of all, the names of all of our panelists. I want to go over who's joining us today on the call. We're very delighted today as our guest to have Dr. LJ Tan. He's the Chief Strategy Officer for the Immunization Action Coalition, and I've had the pleasure to work with LJ for many years in immunization initiatives, and we're very happy to have him with us today. Also talking about immunizations is APhA staffer Mitch Roth, and many of you know Mitch as a person who's been a champion for immunizations in the pharmacy community for more than 2 decades, and we're really happy that Mitch is going to be sharing his knowledge with us today as well. Now, as we move into the payment topic today, we have Alisa Bernstein, who's Senior Vice President of Pharmacy Practice and Government Affairs at APhA, and she joins us about every week to help share information that's late-breaking related to government affairs. But also this week we have joining us Ann Burns. Many of you know Ann is Vice President for Professional Affairs at APhA, and she has been a guru on payment issues related to the breadth of pharmacy practice, and so we're really excited she's here. And this week, like every week, we have Dr. Dan Zlot with us to share his insights related to clinical questions that you may have that have come up during the last week since we met last, and so we'll be taking your questions. Well, speaking of questions, let me tell you how this thing works for those of you who are new. On your screen, you have the GoToWebinar control panel. And in the control panel, you have a function where you can ask questions, and we want you to type in your questions as they come to your mind. We begin collecting those questions at the very beginning. In fact, we already have questions that have been submitted this morning or afternoon, wherever you are. So we're receiving those questions. If your question is selected, then we'll actually call on you and unmute your line so that you can verbally ask your question of the participants. Now, if you don't have audio access and you're unable to do that, you can type in your question and just say no audio, so that'll give me the cue that I need to ask your question for you, and that's okay. No problem. For those of you who've joined us on a handset today on a cell phone and you're not at your computer audio, don't forget to enter your audio PIN. Go ahead and do that now so that when staff unmute your line, we'll actually be able to hear you. So that's very important that you do that. I want to remind you that also in the control panel, you'll see a tab that says handouts. It's a copy of today's slides, and you can pull those up and have them for your convenience at any point. And as a reminder, we record these webinars and post them at pharmacists.com, and it'll be available within 24 hours. And then you'll also be receiving the email link for next week's webinar as well at that point. So all of the housekeeping now is out of the way, and we're going to get down to this discussion. I'm going to ask LJ Tan and Mitch Roth to please turn on their webcams. And we're going to begin a discussion with you guys. LJ, Mitch, welcome. Mitch, I think your line is muted.
Thanks, Michael.
There you are. LJ, great. Thanks for joining us. LJ, your line is muted. If you could unmute your line, that'd be great.
I just did. Thank you very much, and thanks for the opportunity.
Great. Well, we appreciate you being here. Now, a few weeks ago, the CDC published guidance for adult vaccinations, and I understand that there may be some revised guidance that's going to be released soon that might change these recommendations. Could you just lead off and tell us a little bit about how pharmacists should approach the discussion with patients regarding vaccination?
I will take the first stab, Mitch, and then you take over. The slide up here actually is perfect. This slide actually, you know, as Mitch puts this up slide, it was from our summit virtual meeting that was held on May 21st, and it's actually from a CDC slide that talks about some of the messaging that they're trying to come forward with. And so the guidance that you refer to, Michael, that's about to be released, hopefully, we're all fingers crossed, anytime now, will actually try to provide some implementation steps to doing some of these things that they're talking about. And I think the big obvious message that we're going to be hearing from this guidance is this idea that we need to take, in this case, influenza off the table for the fall for so many reasons, right? And the primary reason is obviously the surge to the healthcare system. We want to make sure that we take that as much as possible out of the healthcare system. So vaccinating and increasing our vaccinations for flu this season is incredibly important. And the other thing, as we all know, is that a lot of the risk factors and the risk populations for COVID-19 disease overlap dramatically with influenza. And as a result, if we can get people protected against influenza, we take that out of the diagnostic criteria for providers as well, right? We can try to reduce that burden on the diagnosis of COVID-19. And so while this is flu, I would be remiss if I didn't do my plug and say it shouldn't just be flu, right? It's about all adult vaccine preventable diseases here. Anything that we do to prevent patients from going in this fall, be it pneumococcal disease, be it community-acquired pneumonia or invasive pneumococcal disease, be it shingles, be it pertussis, anything that we do to prevent patients from going into the healthcare system this fall when we anticipate the resurgence of COVID-19 is important. So while this slide is on flu, I personally urge that we should be thinking about all adult vaccines. What do you think, Mitch?
And LJ, just to reiterate your message, it's really what it comes down to. It's the communication between the pharmacist and their patient. Having that discussion about the importance of getting immunized against all the vaccine preventable diseases that LJ talked about is important. And I want to encourage the audience, when you're looking at the definition of that encounter, your interaction, whether it be filling a prescription, providing a patient care service, having a telepharmacy communication, that is the opportunity for you to talk about current vaccines that are available and future vaccines. We've got to get the public comfortable with the new paradigm, which is expect your provider to be wearing a mask. Expect that they're going to have to be wearing a mask. So it's a new dynamic for us in the whole healthcare system, but it's an opportunity for us as well. And so we from APhA and the profession are advocating following the adult immunization standards, which are assess the patient's needs, recommend those vaccines, and then either administer the vaccine if you're comfortable doing it yourself, or refer them to somebody who will, and then documenting it. Documentation during this time is going to be critical for us to track who's gotten vaccinated and looking for reactions as well. So those are important points there that I just want to reiterate in this process.
LJ, before I move on, I want to just get some clarity for our listeners on this point. So, what happened actually with the guidelines that the CDC published for adult immunization? What changed during the COVID pandemic? And then, can you specifically tell us what you think is going to change again here? You referenced that there's likely going to be some changes. So, could you just summarize? You know, we were at point A, then COVID hit, and we were at point B, and now we're about to be at, is it point C, or are we going back to point A again? Tell us what that's about.
Mitch, you want me to take the first crack at that one?
Go for it, LJ.
Just so you want to know, LJ and I have been working together for 30 years in immunization, so we almost read each other's minds. Go ahead, LJ.
All right, so I'm not going to preempt Mitch's mind reading here, but I'm going to say so as we all know, we obviously were encouraging full-fledged immunizations before COVID-19, right? Everyone, you should be assessed, as Mitch says, NVAC standards, right? Assess, recommend, deliver, document. But now with COVID-19, what happened was we hit the shelter in place, right? We hit the ideas of PPE, personal protective equipment, and that threw a monkey wrench into a lot of the traditional routines that we had for getting people vaccinated. For example, there was a lot of discussion and guidance from CDC and others reflected this idea of social distancing and sheltering at home, and there was a feeling that we would be disingenuous if we were telling people to stay home and then at the same time, trying to promote vaccination-only visits. So you saw that dissonance, definitely, that was happening through COVID-19. And I think the change, and again, we all we're predicting here, we don't, the document's not out yet, but I think what we anticipate this upcoming document from CDC is going to flip that a little bit and now say that actually the preventive immunizations that we were doing before COVID-19 now need to resume. They need to be caught up, and we need to continue them into the fall season, regardless of what COVID-19 may present to us. So we want to start vaccinating again. And then we also want to, then as we do that, recognize COVID-19 is going to pop up, and this guidance will give us some ideas of, all right, if you've got this much disease of COVID-19, here are some things you need to start thinking about so that you can continue to deliver vaccines, but deliver them safely for yourself as well as to your patients that you're seeing. So that's kind of a summary of where the switches are happening at a very big level, Michael.
Well, that's great. That's a good overview. Mitch, we're getting questions from our audience already about personal protective equipment, and I wonder, Mitch, if you could comment about that. What PPE should a pharmacist be wearing or utilizing when they give immunizations? I think pharmacists are anxious to get started, but they're a little unsure of what PPE is expected for an immunization encounter. So, Mitch, could you speak to that?
Okay, so we've been hearing since early on that this will be a concern, and we've raised that concern with CDC through the process. And so part of the revisions to the guidances, we've asked CDC to give further guidance to pharmacists and other immunizing providers because we want equity across the system. So whether the patient goes to a medical office or they go to a pharmacy, the same protections for individuals need to be there. And so right now, again, this is all predictions, as LJ said, it looks like we'll be saying, a mask for both the provider and the patient, and it could be a cloth mask for the patient. In terms of the provider, unless you have some high levels of COVID circulating in your area, it looks like it's not going to need to be an N95. Surgical mask will do as well, but expect also to be wearing gloves, but make sure you're changing your gloves between patients. Okay, that's going to be another thing, and frequent disinfecting and wiping down. That seems to be, if I would read the tea leaves right now, the way I've been hearing this discussion, that seems to be what will be coming out in terms of a recommendation. But it's not just what they're telling pharmacists, it's what they're also telling other healthcare providers. And I also want to remind the audience, there's actually two guidances that are important to pharmacy. One is the pharmacy-based guidance, and then there's the vaccination guidance, and they're trying to meld them and make sure they're in concurrence.
Yeah, I know just my personal experience. I had my annual physical exam last week with my primary care provider, and he was wearing an ear loop mask, and I was wearing an ear loop mask, and he actually gave me my TDAP vaccine while I was in for the visit. and that was the standard that they were using, was an ear loop mask for both the provider and the patient. So I think I agree with you. Again, we're reading tea leaves, but it sounds like that's the PPE that'll be required, and not anything more substantial than that, as a fairly low risk procedure. Well, let me move on to this because one of the things that we all know is that Australia has a flu season that's exactly opposite of ours. And we've heard some rumors that Australia has been pretty successful at increasing their immunization rates recently during this pandemic. I'm wondering, LJ, I hear you might know a bit about the land down under, and if perhaps you might share some insights about Australia's strategy and what us here in the U.S. need to consider for the upcoming flu season.
Crikey, Michael, I'm delighted.
Quite good there.
That being said, I think it's interesting what Australia did. So I'm going to launch right into it. Right. So as you all know, they're in their flu season now. So they're in Southern Hemisphere. So they're in winter. So that means their pre-influenza season was essentially, February, March, and April, and into May a little bit. But February, March, and April is where they deliver their vaccines. And as you know, Australia locked down. I mean, really locked down during that time period. So what was interesting was what Australia decided to do. For us, when we locked down, as I mentioned earlier, we went into this, I don't want to say, we went in this like dark gray zone of where, do we encourage people? Do we not? We're telling people to stay home. What should we do? And so we didn't want to be disingenuous, so we kind of just didn't do much. What Australia decided to do was they said, absolutely, everybody shelters at home. Everybody stays at home. Don't come out. Very restrictive. Things will shut down, so on and so forth. But they said, however, flu vaccine is important and you need to go out to get it. So they actually said, shelter at home, but we're giving you the reason to leave your home to get flu vaccine. And then the second thing they said, and when you do that, we will do our utmost to assure you that you will not catch COVID-19 from the healthcare facilities or the other locations that were being set up to deliver flu vaccine. So they had a significant increase in delivery of immunizations in terms of coverage rates. The rates are still preliminary, but they're looking at about a 20% increase from 2019 to 2020 because of their change, their philosophical change, basically, and they put their policy behind it, right? So they set up drive-through clinics, they set up curbside clinics, they set up clinics in parking lots, they figured out how to stage the cars for the 15-minute wait after you give a vaccine to someone who's naive. They did all of that, and at the same time ensured separation. They ensured social distancing. They ensured protective equipment for both the immunizer and the patient. And indeed, with the unified messaging that you shelter at home, but we want you vaccinated, they got their rates up significantly. So that's something I think we all should be looking at. I don't know what the guidance is going to say, but I think that for us, we should be doing a stronger job of advocating the vaccinations for flu as well as other vaccines this coming fall season, while assuring our patients that when they come out to get vaccinated, we will do the best we can to keep them safe from COVID-19.
Well, that's great. And LJ, I know I was looking on the web to kind of look into the Australian vaccine supply issue and noticed that several of the vaccine manufacturers for flu vaccine in Australia had said that they were not accepting new orders. They had actually sold out their capacity because of the increased demand for flu vaccine in Australia. So Mitch, I'm wondering, could you share with us, I know you recently participated in a conference, both of you did actually, related to vaccine supply. Can you tell us a little bit about what our flu vaccine supply here in the US is going to be for the fall? I think we've got a slide on this.
Sure, thanks Michael. So the National Adult Influenza Summit each year has a live meeting. This year it was a virtual meeting just last week, and part of that meeting is the vaccine manufacturers coming and reporting what they project their supply of influenza being for the upcoming season. So on this slide here, you see what was reported out by the manufacturers. Bottom line is that we're going to have 188.75 million doses available in the market. That's a 10% increase over last year. And so there is increased supply available. They're actively taking orders. You see the timing of the dose spec availability. And so you see there in August, for one of the manufacturers that have 75%, but pretty much all the manufacturers expect to have the same timing of dose release as they did last year. The other key point that comes up, it came up in the summit meeting, was the timing of vaccination. And so when will supply be available? When should you start offering influenza vaccination? That is determined by ACIP. And so that there will be further discussions about that from ACIP, but they're right now following the current guidance, which is basically, if you can avoid giving it in July and August because of waning immunity concerns, especially in the elderly, you can start vaccinating and offering vaccination in September. But again, a key part in that recommendation is if you feel the patient won't come back, okay, later on in the season, and you'll have, quote, one shot at them, vaccinate. So take advantage of the opportunity you have with that patient there. We're hoping that ACIP is going to relook at it, especially with the concern of a potential COVID surge that may keep people from wanting to go out.
Great, Mitch. Thank you. We're going to take a question now from the audience. Aaron Butermowitz, and I'm sorry if I said your name wrong, your last name wrong. Brian is going to unmute your line. Aaron?
Hi, how are you? I was just wondering, working in a grocery retail setting, if we don't enforce masks for all of our customers entering the store who might be picking up at the pharmacy or coming up to our window, how do we ensure safety for the patients who want to be immunized in the same vicinity as those customers who are unmasked?
That's a very great question, Aaron. I wonder if Mitch and LJ, you have some ideas on this. I have a couple of thoughts myself, but I will let you guys answer first. Go ahead.
That's the beauty, Aaron. Thank you for the question. That's why we are encouraging clarity in recommendations from CDC, because that gives you something to go back to your management and say, look, CDC is saying for us to do these services, the patient needs to be wearing a mask. If that's what's in the recommendation, patient needs to wear a mask, as well as we, the pharmacy staff, need to. And so that would be one strategy I would use to encourage management to enforce that mask. Again, you've got to be comfortable giving it, and the patient's got to be comfortable getting the vaccine. And those are the two factors that have to come together.
That's right. That's right. LJ, you have other suggestions?
Yeah, so one of the things I was thinking is that you want to think about how you can operationalize it, and recognizing that if you're not going to enforce the mask policy, again, I agree with what Mitch said. I think, use the CDC guidance as leverage. But if it turns out you cannot enforce that mask policy for everyone walking into your store, in that grocery store, then I think you need to operationalize it by recognizing that the guidance for immunization requires the mask from the patient. So what you would do is you would socially distance your immunization sites to give room away from people who are not wearing masks. So 6 to 10 feet, you can create a immunization site. And in that immunization site, before people comes in for immunizations, you mask them. And then they can do whatever they want when they leave the immunization site. But when they're in that immunization operationalizing area, that staging area, they're masked, you're masked, you vaccinate them, then you send them on. So that's how I would think about operationalizing some of these challenges. I prefer Mitch's idea. I think I like the idea of just, I think people should be masked right now because we are still trying to restrict infection. So,
well, this question that we've received from the audience leads me to a polling question I'd like to ask you all. So if the staff will turn up the polling question, we're going to ask you, during the COVID-19 pandemic, how comfortable are you or your pharmacy staff in administering vaccines in your practice? So we've had these questions about PPE and ensuring the safety of patients and your staff. So give us your opinions about this. We want to get you to vote here. Just click on the answer that's representative of you or your pharmacy staff. If you're not personally directly providing patient care, maybe you supervise people who are providing patient care. What do you think their comfort level is? Let's get a few more seconds here. And all right, let's close the poll. And it looks like about half of you have some degree of comfort. About a quarter of you, this doesn't apply because you don't provide vaccines in your practice. And there's another quarter of you that are not too comfortable with this right now because of a variety of reasons, I'm sure. Well, let's get back to the questions. We received a comment from one of our international participants today. Luna Elbizri has just made a comment. You know, maybe community pharmacists could actually do a service by doing home vaccination to high-risk patients like geriatric patients and others, and maybe pharmacists could make those vaccination events at home. What do you guys think about home vaccination for high-risk patients rather than making them come to the pharmacy? What are your thoughts about that?
I think it's a great idea, and I think though the challenge is going to be the patient being comfortable with allowing somebody to come into their home. And so that's I think that's one of the factors we'll have to deal with. But I think going to where the patients are, patients who feel uncomfortable going out of their living facility, will be something that we might want to take into consideration as we look at how to reach patients in the community.
All right, I'm going to take a question now from Jose Cervantes. Jose Cervantes, we're going to Cervantes, we're going to unmute your line for you to ask your question about COVID screening. Okay, let me ask it for him. Should patients be screened for COVID-19 or have their temperature taken prior to receiving an immunization? So I know many are coming into their workplaces now, have their temperature taken before they come into the hospital or before they come into the pharmacy. They have to answer certain screening questions. Are we going to do that? I know most patients do that in outpatient facilities. Are we going to do that in community pharmacies and require, as we open back up, that same level of screening? Do you think it's advisable? LJ, what's your perspective as a non-pharmacist? Do you think it makes sense to do that?
So I'm going to let Mitch, I'm going to defer some parts of that to Mitch, but I'm going to say what I think is that obviously I believe that if you've got a patient that's actively infected with COVID, you're going to be looking to defer vaccinations. So it would be useful to actually know whether a patient is sick coming into the pharmacy to receive immunizations. So the temperature screen makes sense to me because it's something that you're going to want to know anyway. As I believe CDC's guidance will probably indicate that if you got an active patient who's sick with COVID, you want to defer vaccinations. Now, on the bigger picture of screening everybody walking into a pharmacy with a temperature screen, I think Mitch is probably better equipped to answer that. But to me, it's something that we want to do, so it makes sense to implement that. But Mitch, I think you know better about the big picture here.
And I'm just going to add to that, LJ, is our comments to CDC. Ask them to give clearer guidance on that. And I'm where LJ is. I think it's a good practice to screen individuals so you know if you're dealing with somebody who has some symptoms that you would maybe want to defer for them, particularly the immunization.
So that's great answers, and I think there's going to be a lot of things that we have to really just look at best practices. This is a pandemic that's new to all of us, so everything that we're experiencing is new. So we use our best judgment to make the best decisions that we can and move forward. Now, we've got really an interesting question here by Saida Tasseff, Tasseff, and I'm going to have Brian unmute her line. But as this question is coming, I just want to point out that as we are all aware, there are certain areas of the country where we have outbreaks at any given time and another. Sometimes there's a huge COVID outbreak going on. Another community may have very little COVID going on. So things are different from one community to another. So Saida, would you like to ask your question?
I suppose so. I was wondering, so I'm in Oakland County, Michigan, and for a while here, things weren't that great, and especially in the city that I'm in. Just wondering how exactly would we prioritize doing vaccinations when does that count as an active community outbreak? Would that be a time where you wouldn't want to vaccinate? Or how exactly would you determine if it's an active community threat.
Well, yeah,
That's a
I'll
great
start
question.
with
Go ahead,
I'll
Mitch.
start with an LJ. I think one of the things you want to look at, thank you for the question. You want to look at what's going on in terms of the color coding of your area, whether it's in a red zone. That'll be the guidance that a lot of providers and in the community will be following in terms of what's going on overall in your community. Again, if you're also screening for individuals with symptomatology, or if you're in a red zone, you might want to consider additional safeguards in terms of eye protection or a face guard. Again, it's really trying to find out what public health is saying in your community and what guidance are they given, not just to retail pharmacy, but to healthcare providers in your community. That's what we want to be held the same as. We're no different than the physicians and nurses in the community. Those are the same safeguards that we want to make sure we have too.
Yeah, and just to, on the science level, the higher level, in terms of your personal safety, even if there's a community outbreak, is that immunizations, even with the nasal spray, with flu mist, it's not considered a high risk for aerosolization activity. So it's not one of those high risk activities where you anticipate expelling COVID-19 droplets everywhere. So that's one of the reasons why, as Michael was saying earlier, mask and gloves, generally gloves is added, but mask is protective enough. So that's the big science picture with regards to immunization as an intervention, and it's not a high risk for aerosolization. But I think the rest of what Mitch says is exactly right. I mean, you look to your public health agency, and maybe they might say, if you're in an active outbreak community, when you vaccinate, you might want to put on something else that will protect your mucus linings in your eyes and your nose and other places against splash. And that's about right. So yeah.
Okay, well, we're getting lots and lots of questions, and we are going to now ask the two of you to mute your webcams, and I'm going to invite Alisa Bernstein and Ann Burns to come on to share a little bit of information with you about payment for COVID-19 testing. And folks, we will continue Q&A after Alisa and Ann share their information. We'll take more of your questions about vaccines or any other topic that you'd like to talk about. So Alisa, Ann, please share with us the late breaking information and wisdom that you have from your meetings with CMS.
Great, thank you. Yes, so as Michael just said, Ann and I are going to share some information that we've learned over the last actually week or two from various meetings with CMS and other policymakers. First, I'm going to give you just kind of set up the scene of what's been happening in the world of testing, and then Ann's going to give you some specific, really practical guidance. So as we've been telling you, if you've been watching our webinars, or in early April, the HHS issued guidance that authorized licensed pharmacists to order and administer COVID-19 tests, including the serology tests. And those are the tests that FDA has authorized. And although some states issued declarations or clarified that licensed pharmacists can order and administer the COVID-19 tests, other states limited or prohibited pharmacists from performing these tests. So there remains to be some questions of how the state scope of practice related to the new pharmacist testing authority. So to clarify this, about 10 days ago, an HHS issue, this is the US Health and Human Services, they issued an advisory opinion that concluded that licensed pharmacists may order and administer COVID-19 tests, even in states that prohibit licensed pharmacists from ordering and administering these tests under their scope of practice. So we actually, I'm going to pause a moment and answer a question that we got from the webinar audience that really fits right here. And the question was whether this authority includes state CLIA requirements that are barriers to testing. And it's a really good question. And the HHS opinion is clear in explaining that the law preempts any state or local requirement that prohibits or effectively prohibits a pharmacist from ordering and administering COVID-19 tests. So that's broad. So it would cover these types of state requirements. And there are some states where this continues to be a barrier, and APhA is working with NASPA and other pharmacy organizations to address these remaining state barriers. Before Ann talks about billing and payment, let me just walk you through some really high-level steps of what's required for payment purposes. Well, first you need to get a CLIA certificate of waiver. Next, you would enroll with Medicare as an independent clinical laboratory. And this gives you the ability to bill as a lab. The authority that HHS provided only covers pharmacists' authority to order and administer tests that are authorized by FDA. And so these would be authorized under an emergency use authorization. And FDA lists on their website which tests are authorized under an EUA and in what settings they may be performed. Can you go to the next slide, please? So here's a snapshot of FDA's website. And you could just Google FDA COVID diagnostic tests and get to this website really easily. Tests with a W are those that are authorized to be used in patient care settings. And that includes pharmacies. And we worked with FDA to provide clarification that a pharmacy is a patient care setting. So this list here lists those molecular or diagnostic tests and the serology or antibody tests that can be used in various settings. And the W is what you should be looking for. And that's how you know which tests are authorized. If you could go back momentarily, please. So how do you get paid? And this is what Ann's going to talk about. But it does depend on patient's coverage, what services you are providing. And ideally, pharmacists would get paid for the test, performing the test, and the clinical services associated with providing the test. So this includes assessing the patient, ordering the test, collecting the specimen, in some cases handling and shipping the specimen, conducting, interpreting the results, notifying the patient about the results, and then reporting the results to the appropriate state, local, and federal authorities. So these are the services that are associated with providing the test. And so different types of pathways provide different payments. And that's why I'm going to now turn it over to Ann to describe some of those pathways and how to do that.
Great. Thank you, Alisa, and welcome everyone to this portion of the webinar. I'm going to be going over a very high-level overview of what we know about testing, and just say that we're developing resources. There will be more detailed information coming, but this will at least give you a flavor for what payment is starting to look like. So CMS and HHS have been issuing a variety of different guidances that have been very welcomely calling out pharmacists and their potential contributions to testing. And this is just a snapshot from one of the guidances that shows two different pathways for payment for involvement in testing. So the first one, as Alisa mentioned, is payment for conducting the test. So actually conducting the test, and this will be in an entity that is registered with CMS as a clinical laboratory. And it's really envisioned that this would be a pharmacy. There may be other potentials. The second potential payment pathway is related to the services that would accompany the testing. And there are a couple of different options. The most predominant one seems to be working with a physician under a contract where the physician bills and then the pharmacist gets paid under the terms of the contract. And I'm going to talk about both. Before I move on, I also think that it's worth mentioning that CMS has clarified that during the emergency, beneficiaries will not pay any co-pays or cost shares for COVID testing and services during the period of the emergency. So just a good thing for pharmacists to know as we all get into this in a greater degree. And then I also wanted to call attention to the link at the bottom of the slide because there's a lot of great information in this particular document, including the payment that CMS is providing for testing and some of the services I'm going to be talking about. So next slide. So we're going to start with payment for conducting the test, and as Alisa mentioned, the pharmacy will need a CLIA waiver, certificate of waiver, and then the pharmacy will need to enroll in Medicare as an independent clinical laboratory. And the form that is filled out in order to enroll in Medicare as a laboratory is called the CMS Form 855B. And this diagram is just showing the box that you check to enroll as an independent laboratory. That application goes to your local Medicare administrative contractor. There are a number of these across the country by geographic region, and the application needs to be submitted to the contractor. The turnaround has been very good from what we're hearing, and the other great thing right now is CMS is waiving the fees to enroll in Medicare, so that saves hundreds of dollars. Then the pharmacy will be issued a Medicare provider number. The technical name is a PTAN, or a provider transaction access number, that will allow the pharmacy to bill for COVID tests that are conducted as a laboratory. So from there, the pharmacy will conduct tests and submit bills, and we'll provide more details about that later. But I think it is also worth mentioning that CMS has clarified that pharmacists can not only conduct COVID-19 tests, but they also can conduct influenza and RSV tests if they are conducted concurrently with a COVID-19 test. So just good to know for an opportunity for pharmacists in treating patients with potentially suspected COVID. So next slide. This is just an example of some of the different billing codes. That's a question we're getting a lot right now. What kind of codes do I bill when I'm conducting tests? And there are a number of them, and more emerging all the time. The bottom line is that it's best to use the code that reflects the type of test that is being conducted. And as Alisa mentioned, there are specific waived tests for patient care settings that pharmacies can conduct. I will note, though, if you look on the left, there is a code U0002 that is kind of a catch-all code for any type of COVID test that is delivered for diagnostic purposes. So if you're not sure, CMS has said that that particular test can be billed. So that's just the brief overview on COVID testing. If we can move to the next slide, we'll spend just a couple of minutes talking about the types of testing related services that can accompany a COVID-19 test. So CMS has envisioned that the types of services that wrap around a COVID test are what they call either basic clinical services, or they also call it patient assessment and specimen collection services. And scope of practice related to specimen collection is a consideration related to these services. As we all know, and unfortunately, pharmacists are currently not recognized as providers who can bill independently for their services in the Medicare program, but rather pharmacists are considered as auxiliary or auxiliary providers or clinical staff. And because of that, there needs to be a workaround for how pharmacist services can be covered. And where CMS has landed and provided some clarification is in an area that we call incident to billing, or incident to physician services arrangements. So under these arrangements, A pharmacist partners in a financial relationship with a physician or other other qualified non-physician practitioner, NPP, who would bill for their services, and then the pharmacy or pharmacist would be reimbursed according to the terms of the financial relationship. These services are very common for pharmacists who work in physician office practices, who actually may be salaried employees of the physician practice. The other key requirement for Incident to services is a supervision requirement that in normal times requires the pharmacist to be physically co-located in the physician office suite. But in times of COVID, CMS has relaxed that requirement to allow for supervision using audio and video real-time technology. So that's an expansion that potentially allows for new types of relationships and coverage of pharmacist services. The code that CMS is advocating for this type of service is what we call a level 1 office visit or an evaluation and management code. It's CPT code 99211, and it can be used to bill for these basic clinical services, and interestingly, to both new and established patients of a physician practice. So that's another expansion that will help pharmacists to potentially use this mechanism. So if we can move to the next slide, which is also the last slide. There are just a couple of other possibilities related to payment, and they relate to specimen collection. Usually specimen collection is part of regular physician services. But CMS has clarified 2 new specimen collection codes. One can be used by clinical staff who are in outpatient hospital departments, and the other, it can be used by laboratories if the specimen collection occurs in the patient's home or a skilled nursing facility. So there are very specific requirements. The end result is there are not a lot of options in a pharmacy, for instance, for specimen collection, unless it's an incident to physician services relationship like I just described. So stay tuned for more information. We're going to be providing details as we get them, and as always, we continue to advocate for sustainable mechanisms for payment for pharmacists, COVID services, as well as others. So really appreciate the opportunity to share this information. And Michael, I'll turn it back over to you.
Thank you so much, Ann and Alisa. I'm going to ask a couple of questions here. The first one comes from pharmacist Aaron Duvall, and Aaron asked the question, are pharmacies or pharmacists allowed to administer tests, i.e. collect the sample, that are not designated with a W if they partner with a lab to continue with performing the test? So a few weeks ago, Alisa, if you'll remember, on this show, we had a guest, a pharmacist, who was actually doing COVID testing that was not one of the ones with the W. Is that allowed for if the specimen's being handed off immediately to the lab and the lab is actually doing the billing for the test?
Yeah, so if you're just doing the specimen collection, that's different than actually conducting the test. And there are these arrangements that labs are having with pharmacists. Yes. Okay.
All right, great. And another question here, Amanda Applegate. Can we unmute Amanda Applegate's line for her to ask a question?
Thank you. So one question I have is, we've looked into obtaining the clinical lab certification through Medicare, but we are already enrolled with Medicare Part B as a, I believe, pharmacy or mass immunizer, so we already have a PTAN number and are waiting for clarification on if we can also enroll and get a separate PTAN number to be able to bill as a clinical lab.
Hi, Amanda. It's our understanding that yes, you do need to, if you want to be enrolled as a lab, you do have to enroll as I mentioned, as an independent clinical laboratory, in which case you would have 2 PTAN numbers, and that may present some additional logistical issues for billing a variety of services through Medicare when you have 2 numbers. We have posed that question to CMS and asked them to consider basically combining the types of services that pharmacies would offer so they wouldn't have to deal with several different numbers. And this becomes even more important after the emergency when you have to also maintain several numbers and pay new enrollment fees for each number, as well as the billing challenges. So it's a great question.
One other question that we've gotten from a couple of other attendees as well is some state departments of health are continuing to require pharmacies to register for CLIA waiver, and there's some confusion about the HHS clarification that was put out a couple weeks ago. So does HHS saying that pharmacists can conduct these tests trump a state health department's ability to require pharmacists to register as CLIA labs? There's some confusion on this. Alisa, could you expound on what we need to know?
Well, the state health department still has authority and they have oversight. However, based on the opinion, they can't put barriers in place that would prohibit a pharmacist from actually ordering and administering tests. So they'd have to change that requirement, the law, and these are some of the things that we're working with. We've heard some states require that the pharmacist has to have 2 hours of lab experience before that they can get the certificate. In another state, it can't be a pharmacist who's the lab director. So these are the types of barriers that are examples that have to be lowered. And some states are are unclear if they're going to be doing it. And so that's what we're working with to try and eliminate those barriers.
Okay, well, I tell you what, this hour has gotten away from us. I do want to just briefly ask LJ Tan and Mitch Roth to rejoin us. I'm going to ask one more immunization question before we close out. Alisa and Ann, thank you for being with us.
Thank you.
Folks, we will try to address additional billing questions on our website at pharmacists.com and the Engage platform. But I do want to just close us out today with, and guys, I'm going to ask you to be brief with your answers on this. We know that COVID-19 vaccine is coming, and we intentionally today did not spend any time talking about COVID-19 vaccine. However, if you could whet our appetite just a little bit, LJ or Mitch, what do you know about the timing or the likely timing of a COVID-19 vaccine being in the marketplace based upon the evidence and data that we have today? What timing are we thinking? When might we expect a vaccine?
Mitch, you want me to go first?
I'm going to let you take it.
All right, so just for you all know, Michael, on the Summit website at itsummitpartners.org, there's an entire webinar where we feature 6 of the manufacturers for COVID-19 vaccines from May 12th. I encourage your listeners to go see that. But based on everything we're seeing with phase 1 and phase 2 trials currently undergoing, we anticipate that a lot of these innovators will enter phase 3 trials probably in the fall, going into the winter of this year. We know that some of these innovators have capacity in terms of changing their facilities to ramp up fill and finish, so that they can actually produce and deliver millions of doses in the spring if everything goes well. So that includes obviously also FDA approval that the vaccine is safe and effective as well. So in terms of your answer to your timing question, something in the fall, with end of phase 1, phase 2, entering phase 3 trials, and ramping up delivery of maybe vaccines to hundreds of millions of doses in the spring. So that's a everything goes well scenario.
And just to add, Mike, to that is we don't know the timing in terms of supply. It'll probably be a phased-in process, but pharmacies should start preparing and looking at their practices and who their patients are that they serve, and thinking about who the targeted patients coming out will be, and demonstrate that they too can serve those patient populations.
All right, well, LJ and Mitch, thanks for joining me again. I appreciate you being on the show today. I want to share just a couple of closing things with our closing items with our audience. First of all, we know that we've got a few things going on at APhA. I'm impressed every week at the activities the staff and leadership are involved in working on your behalf. For example, we have 2 new episodes of APhA's 15 on COVID-19. Folks, if you haven't checked these out, I really encourage you to go to pharmacists.com and take a look at these. These are 15 to 20-minute segments, real brief tidbits of information for which you can get CE. There's now 17 episodes available, and that's a lot of information, but really helpful tidbits that you can get in your day of quick information. Also, we want you to know that there is additional practice resource available this week that you should take a look at. There's a summary of the vaccines that are in development for COVID-19 to follow up on our conversations that we shared with you today, and also some testing resources that you may find helpful based upon the conversations that we had today. And the staff is working weekly to provide additional resources to you for use in your practice. So all you have to remember is to go to pharmacists.com, and on the top banner you see a COVID-19 banner. Click on that, and all of these resources, including the previous episodes of this broadcast, are available to you there. Now, one action item I'm going to ask is that we're hoping to have at least 10,000 pharmacists submit a petition to Congress asking that pharmacists be added for payment, clear payment under Medicare Part B and through the Medicaid programs. And we would just ask that you would please take action today by going to actioncenter.pharmacist.com and filling in this information. It takes 2 minutes. We are literally 800 people away from hitting our 10,000 person target. Please promote this to your friends, put it out on your social media. Let's see if by the end of the day today we can't hit our 10,000 person mark in terms of telling Congress that we need to be paid adequately and equitably for these COVID-19 tests. Now, one last thing I mentioned earlier, that Engage is our platform where you have the opportunity to ask your questions of your colleagues, to get insights from each other, and share the things that you're going through in your practice that are unique during this COVID-19 pandemic. We would encourage you to take the time to go to Engage and participate. For those of you who are listening today who are not currently APhA members, I really want to promote to you that APhA is fighting for every pharmacist, but we need you to join, and we need you to be a supportive member. It's only about $125 to join APhA. It's a pretty affordable thing to do, and we really would ask that you take a moment today and join APhA and engage in these conversations that we're having. Now, next week, we'll be back at the same time and same place with another exciting topic, and we'll look forward to engaging with you in those conversations. The topics will be released tomorrow, and I'll leave that teaser for you so you'll look up what we're going to be talking about next week. I want to just say to all of you, thank you, thank you, thank you for everything that you're doing in your communities, for your staff. We know that this is a difficult time for everyone as our nation begins to reopen a bit and people begin circulating around. There's a lot of fear, and you, the pharmacist, I know, are the voice of reason and calm in your communities, but you also are trying to take care of your staff, and we appreciate that and everything that you do each and every day. So thank you to each and every one of you. Thank you for joining our webinar this week. Take care, and God bless.